It's my pleasure to present to you, on behalf of my all co-authors, the long-term follow-up of ZUMA-1, a pivotal trial of Axicabtagene, ciloleucel, or also called as Axicel, in patients with refractory, aggressive, non-hodgkin lymphoma. Here are my disclosures. So what we are presenting today is the updated analysis on ZUMA-1, where we pooled data from the phase 1 portion of the study, where we treated 7 patients, and the phase 2, where we treated 101 patients. To be eligible for this trial, these patients had to have refractory diffuse large B-cell lymphoma, primary mediastinal B-cell lymphoma, or transformed follicular lymphoma. They should have had no response to the last chemotherapy or should have relapsed within 12 months after prior auto-transplant. And they should have received adequate prior therapy with anti-CD20 monoclonal antibody and anthracycline-based chemotherapy regimen. Following the manufacturing of the product, these patients received low-dose conditioning chemotherapy with cyclophosphamide and fludarabine, and 2 days later received the Axicel at a fixed dose of 2 million CAR-positive cells per kilogram. Importantly, 99% of the patients who were enrolled had the product manufactured, and 91% of the enrolled patients were dosed with Axicel. So this pooled analysis has a total of 108 patients with a data cutoff of August 11, 2017, when we had a median follow-up of 15.4 months. Here are the baseline characteristics. The majority of these patients were advanced stage disease with stage 3 or 4, had high-risk disease in about half the patients. These patients were heavily pretreated with 3 or more prior lines of therapy. 74% of the patients were refractory to 2 or more prior lines of therapy, and 23% of the patients relapsed post-auto-transplant within 12 months. What this reflects is that 3/4 of these patients could never get to a transplant, highlighting the refractory nature of these patients. In addition, 2/3 of the patients were having progressive disease to the last line of therapy prior to study entry. Here's the updated analysis. On the left, in this table, you can see the primary analysis. In the updated analysis of 108 patients with a median follow-up of 15.4 months, the best objective response rate was 82%, and the CR rate was 58%. 42% of the responses are ongoing, with 40% in complete remission. We've had some patients who had conversion from stable disease to partial remission, from partial remission and stable disease to complete remission up to 15 months post-infusion without additional therapy. The median time to conversion from PR to CR was 64 days. This durability of these responses have been observed consistently across key covariates, including advanced stage disease of these patients. The high risk or low risk did not matter. The refractory status of these patients did not matter, nor did the CD4 or CD8 ratio of the product, and whether the patients received tocilizumab or corticosteroids. The median duration of response for all patients was 11.1 months, and the median duration of response for the CR patients has not been reached. We've had 3 patients from the phase 1 trial who have an ongoing complete remission 2 years after infusion of a single infusion of Axicel. At a median follow-up of 15.4 months, 42% of the patients remain progression-free, and 56% remain alive. On the PFS curve, you can see there's a plateauing of the curve appearing around the 6-month time point. The median overall survival has not been reached. The estimated 18-month overall survival rate is 52%. Here's the summary of the adverse events. The adverse events on the primary analysis were previously presented. In this updated analysis of 108 patients, the grade 3 or higher cytokine release syndrome was observed in 12% of the patients, and grade 3 higher neurological events were observed in 31% of the patients. There were 4 grade 5 adverse events. All of these adverse events have been previously reported. The one additional adverse event compared to the primary analysis was previously reported on the phase 1 portion of the study. Since the primary analysis of at least 6 months of follow-up, there has been no new Axicel-related CRS or neurological events or grade 5 adverse events. Most patients experience hypogammaglobulinemia and B-cell aplasia as expected with this therapy, but only 8% of these patients received IVIG support. This table summarizes the serious adverse events that have been noted after the primary analysis of at least 6 months. We observed serious adverse events in 10 patients, but almost majority of these were infections. And these infections, as well as other adverse events, have all resolved by the time of the data cutoff. So in conclusion, at a median follow-up of 15.4 months, 42% of the patients have ongoing remission, and the median duration of response for the CR patients has not been reached. The median overall survival has also not been reached at this point. Late onset adverse events were primarily infections and were quite manageable. There was no late onset CRS or neurological events that were noted related to Axicabtagene therapy. We also did not observe any replication-competent retrovirus or insertional mutagenesis. Durable responses were observed with and without detectable persistent CAR T cells in these patients. In preliminary analysis of biopsies at the time of progression, we observed at least 2 potential mechanisms of relapse, one due to CD19 loss, and a second due to possible immune checkpoint expression, such as PD-L1. So in summary, these results suggest that Axicabtagene is highly effective in patients with large B-cell lymphoma who otherwise have no curative treatment options. These results are now published online on the New England Journal of Medicine website as of today. So with that, I'd like to acknowledge the patients and the families who participated in the study staff, and the healthcare professionals at the various institutions, and the funding support from KITE and Leukemia and Lymphoma Society. Thank you for your attention.